Hello, good evening. Today we are going to discuss head and neck surgery, eMRCS question bank. We start now with all participants reading the question, then get the answer, and we will discuss all the question together with related topics and related questions as well. Okay, so let's start our first question with Dr. Aruna. Okay, you can start.
Yes. Should I read it loudly or I can just answer myself in chat?
No. Just you read the question and with loud voice, please, and then guess the answer, and we will discuss the answer together.
Okay, thank you. A 34-year-old lady presents with a long-standing offensive discharge from the ear, and on examination is noted to have a reduction in her hearing of 40 decibels compared to the opposite side. What is the most likely cause? Options: otosclerosis, acute otitis media, cholesteatoma, long-standing perforation of the pars tensa, otitis externa. My answer is long-standing perforation of the pars tensa.
Okay, anyone have any other answer?
C. Cholesteatoma.
Dr. Ghada, cholesteatoma, yes.
Yes, cholesteatoma.
Cholesteatoma, yes.
Yes. Okay. Yes,
cholesteatoma.
exactly. Okay. Questions of ENT are very clear, not confusing. Mostly you'll have the keyword is very clear. We will see during our discussion. It's one of the question of the ENT, which is asking about a long-standing offensive discharge in a middle-aged female. Okay, this is cholesteatoma. Cholesteatoma is a long-standing condition with very offensive discharge. Okay, it's not confusing, has no other related questions. We'll find maybe another question in a very young child have discharge but not offensive with severe ear pain, and this is very common condition in a child, which is the otitis media. Other than this, we don't have any other cause of discharge except this condition. Okay. Next question. Okay, please, anyone has noise background, just mute himself, please. Anyone new wants to participate? We already have 4 participants. Anyone new wants to participate, just raise hand. We can add him as well. Just read the question and then guess the answer. Okay, so we can add Dr. Ghada, Dr. Jada, or Dr. Ghada, Dr. Safa. Dr. Ghada, okay, we can add Dr. Ghada as well. So now, as we said, so Dr. Aruna, we started, Dr. Ghada, Dr. Sahar, Dr. Mahbub, then Dr. Ghada again, okay? So third now is Dr. Ghada Nig. You can go, start.
Okay, a dentist treating a woman with rheumatoid arthritis for a recurrent episode of dental sepsis noticed that at both parotid and submandibular glands are symmetrically enlarged. What's the most likely diagnosis? Sjogren's syndrome, Mikulicz syndrome, alcoholism, liver cirrhosis, metastatic cancer. So in this patient, she has both the parotid and submandibular gland enlargement, and she has a history of rheumatoid arthritis. So it may be either Mikulicz or Sjogren's syndrome, but there is no Zika features, no dry eyes, no dry mouth. I think it's B, Mikulicz syndrome.
But it is related to an autoimmune disease like rheumatoid arthritis.
Yes, but there is no history of dry eyes and dry
Not
mouth.
Very important to mention it. But he just told you that she has salivary gland problem. Salivary gland problem that maybe causes dry mouth, xerostomia, as they say sometimes.
So Sjogren's syndrome.
Exactly. Okay. Any bilateral? We have no other question in the exam. The answer is Mikulicz syndrome, by the way. I didn't face any question in our question bank or in all recalls have this answer, but Sjogren's syndrome is very common in exam and is very common in question, and they come with different scenario. Sometimes tells the patient has bilateral submandibular gland and parotid gland, so bilateral salivary gland problem together with an autoimmune disease like rheumatoid arthritis. Yes. Okay, so just okay, exactly. He wants to tell you this is an autoimmune problem. Okay, here see equals is similar but with no Zika or arthritis. That's the difference, and most questions will come with arthritis, xerostomia, and keratoconjunctivitis Zika. Most questions, by the way. We have another one which is a little bit confusing. He will have a bilateral parotid gland swelling, mostly together with he tell you that the patient is hypercalcemic. Sarcoidosis, and this is the most two questions come by bilateral salivary or bilateral parotid gland affection, one with autoimmune disease, which is rheumatoid arthritis or any other, xerostomia, keratoconjunctivitis, which is Sjogren's syndrome. The other one is the patient is hypercalcemic, and he tell you some like the patient has some pancreatitis or other hypercalcemic disorders, which is the sarcoidosis. Okay?
Okay.
Just be clear, questions in eMRCS, not confusing. Mostly more than 75 to 80% is straightforward. More details about some question is not needed. We have enough confusing questions in many branches, so just be particular to the answer, and he won't just you to know some superficial information about everything. The idea of eMRCS, he wants you to know something about everything, and he don't want you to know everything about one thing. Okay, just put this in your mind. He wants you to know something about everything, so you can reach the diagnosis so fast. You can just know what is this problem, even superficially, and then you can refer it to the main specialist, some neurosurgeon problem. So you can search ENT problem. Oh, this is mostly cholesteatoma, but it needs an ENT. He don't want you to know everything about the pathology of cholesteatoma, treatment of cholesteatoma, how to diagnose cholesteatoma, how to follow up the patient. No, just want you to guess the diagnosis, like spot diagnosis from some little symptoms and from one or two keywords. Okay, and you will find this in part B when you are going to take in history station. Okay, so you have to do every differential diagnosis. So if you want to ask about a back pain, so you have 5-6 causes. Every cause you will ask 1 or 2 questions. You don't want to ask many questions about some problem. So if it is a metastatic disease, he will tell you, just ask him, you have any loss of appetite, loss of weight, or any constitutional symptoms? No. He wants you to ask about something like lumbar disc prolapse. Do you have leg pain or neurogenic pain in your legs? No. So just be superficial in your answer. Don't go for now I did know this is Sjogren syndrome. I don't want to know more details about Sjogren syndrome. This is sarcoidosis. I don't want to know more details about it. Really, it will make you more confused, many information in your mind, and at a certain point, it will give a negative drawbacks and negative effect in your thinking and in your answers. Okay?
Okay.
Okay, so next question, Dr. Sahar.
A 29-year-old man has had sore throat for the past 5 days. Over the past 24 hours, he has noticed increasing severe throbbing pain in the region of the right tonsil. He is pyrexial, and on examination, he is noted to have swelling of this area. What is most likely cause? I think my answer, Quincy.
Exactly, this is a throbbing pain. Throbbing pain is with abscess. Exactly. If anyone just knows what's throbbing pain, we see it in abscess. So we just
peritonsillar abscess.
Peritonsillar abscess. It is not glandular fever. Okay, it is not common cold. It is not lymphoma. It is not a cancer. All this not come with throbbing pain. Okay, I think anyone have two devices, just turn off the other device because I can hear double voice. Anyone with two accounts or just opening another account? Okay, so this is currency. Okay. Next question, Dr. Mahgoub. I think Dr. Aruna, you have a loud voice. Yes.
Okay. 42-year-old singer is admitted for a thyroidectomy. Post-operatively, she is only able to make gargling noise. Her voice sounds breathy. What is the most likely diagnosis? This is bilateral her voice sounds breathy.
What means by breathy?
Open airway.
Some resistance in the air. Some dyspnea and breathing.
Some dyspnea. This means
some hoarseness and breathe. Sorry, voice sounds breathing means be some hoarseness of voice. So what do you expect here?
Unilateral, recurrent laryngeal. Unilateral, yes. Inferior laryngeal nerve.
Okay. Let's clear this point. Exactly, it is unilateral, recurrent, or inferior laryngeal nerve. Okay. Let's clear this point. Okay, we have the laryngeal nerve. Okay, laryngeal nerve is two partition: internal laryngeal and external laryngeal. Okay, Internal laryngeal is sensory. Internal laryngeal is sensory. External laryngeal I just want to make it clear. External laryngeal is motor. Okay. We have external laryngeal gives us inferior and superior laryngeal. Clear? Inferior laryngeal, which is the recurrent, gives all muscles of the larynx. Superior laryngeal gives us cricothyroid, which is responsible for tensing the vocal cord. Okay?
Okay.
This is briefly the larynx. Internal sensory, external, inferior, superior. Inferior, which is the recurrent, give the all muscles of the larynx except of the cricothyroid, which is supplied by superior laryngeal. Okay?
Okay.
Go for the more important. How we can differentiate easily between injury of the recurrent laryngeal nerve. So we said superior laryngeal, we just talking about loss of high-pitched voice. Okay? This is clear. Okay? Go for the recurrent laryngeal. We have unilateral recurrent laryngeal. We have partial, injury, and we have complete injury. Partial, we have unilateral, we have bilateral. Complete, we have unilateral, and we have bilateral. Till now clear?
Yes.
Okay. Partial P breathing. Okay. Partial breathing. Complete voice. Clear till now?
Yes.
Unilateral partial will make dyspnea. Bilateral will go for stridor. Unilateral complete will go for hoarseness. Bilateral complete will go for aphonia. Is it clear for all?
Sir, just one question.
Clear for all?
Yes, yes.
Yes.
Again, recurrent laryngeal injury. Partial, it is breathing. So if it is unilateral, we will have dyspnea. If it is bilateral, we will have stridor. Complete with voice, C with C. Okay, complete voice. So if we have it partial, we have it portions of voice. Sorry, unilateral, it will be portions of voice. Bilateral, we will have aphonia. If you want to know clearly why partial makes dyspnea and bilateral causes stridor, it's a complicated function of the vocal cords. Okay, because the adductors is more strong than the abductors. So in partial injury, the adductors will act and overact the abductors and will close its site on the vocal cords, and it will close its half of the larynx. But incomplete, both adductors and abductors will be paralyzed, so the vocal cord will be in the midline, so still some air coming and go, but there is no voice. Who's asking about the superior? The superior laryngeal, we have just loss of high pitched voice. He tell you he can't sing, or he can't give a high pitched voice, or he can't tell words with high pitched voice. This is the superior laryngeal, because it is only the cricothyroid muscle which is responsible for tensing the vocal cords, like a music machine, like a guitar. If it is not tense, it will not give the high pitched voice. So in superior laryngeal injury, the vocal cords loss, it's tense and it will be relaxed, so it can't give the high pitched voice. Clear?
Clear.
This is simply,
Clear.
you don't need to know more details about. Okay. If someone wants to know some to why partial, as I told you, this is the vocal cords. This is here, sorry, the entrance of the larynx, and this is the vocal cords. If we did like this and this as example, okay, this is abductors make like this, and adductors close the vocal cords. So this is abductors and this is adductors. This is abductors and this is adductors. Okay. When there is a partial injury, the adductors is more strong, so they will overcome the action of the abductors and they will bring the vocal cords in the midline. So if it is partial, so only one will be functioning and the other one not functioning. So the partial will affect the voice. Okay, because this is moving, but this is not moving. The adductors overcome. But if it is complete injury, okay, if it is complete, the vocal cord will be in the midline. So here the abductors and adductors both will be lost. So the breathing will be fine, but the problem with complete will be with voice, C and C. But in partial, the problem will be with breathing. So if bilateral partial, the vocal cords both will be closed. So it will be stridor. But in bilateral complete, the vocal cords will be like this. So breathing is intact, but there is aphonia. Anyone understand? Or difficult?
Yes, I get it.
You got it, okay. Just you need to concentrate in the movement of the vocal cords and the abductors and adductors. Okay, I hope it is clear now. So we have 1 or 2 questions in the exam about the injury of the vocal cords. Whatever here or in anatomy of head and neck and paper 1 or paper 2, just you have to concentrate and to know it simply as we illustrate it. Okay, let's go for the next question. Here is here is, as we said, superior laryngeal just the Greek thyroid muscle, but the recurrent laryngeal all the intrinsic laryngeal muscles. Okay, and both of them are the branches of the external laryngeal, but the internal laryngeal is just sensory. Next question, whose turn? Dr. Ghada Safa.
Yes. Okay, 53. Okay, so just a minute. Okay, 53 years old man present with mass lesions slightly inferior to the tragus of his right ear. FNA and ultrasound are performed and 2cm polymorphic adenoma diagnosis. What the most appropriate course of action? Ultrasound guide cord biopsy, radical parodontictomy, superficial parodontictomy, discharge MRI. I think it's superficial. See.
Exactly, it is partial or superficial parodontictomy, in which we remove the superficial lobe of the parotid gland because it is pleomorphic, benign
Yes.
pleomorphic adenoma. Okay, so we come here for some clearance of about some issues about the tumors of the salivary gland. I think most of us know the rule of 80, yeah? Yes? You know about this?
No.
Okay. Okay, rule of 80 says that 80% of salivary gland tumors, 80% are in the parotid. And 80% of the parotid are benign. And 80% of the benign, or about 75%, are pleomorphic adenoma. Clear?
Clear.
Okay. This is the first issue. Second, most common benign tumor is pleomorphic adenoma. Most common malignant
state.
Mucoepidermoid.
Mucoepidermoid.
Mucoepidermoid carcinoma. But most common malignant with epineural invasion or
Adenoid cystic.
yes, or facial palsy, you will go for adenoid cystic. Clear?
Yes.
So most common benign is polymorphic adenoma. Most common malignant is mucoepidermoid carcinoma. Most common malignant with epineural invasion or facial palsy is adenoid cystic. Sorry, I said adenoma, so it's a polymorphic adenoma, adenocystic carcinoma. Sorry. Okay. So in malignant tumor, we do radical parodontectomy, but in benign tumors, we do superficial parodontectomy. Clear?
Yes.
Yes.
Okay. Next question. Whose turn? Start again from Dr. Aruna.
Yes. A child is brought to casualty complaining of a headache and a sensation of pressure between the eyes. On examination, she is febrile with a smooth swelling overlying the superior medial aspect of the right eye. The eye is uncomfortable and there is a purulent discharge from the inner canthus. What is the most likely cause? Maxillary sinusitis, ethmoidal sinusitis, nasal polyps, ethmoid sinus cancer, maxillary sinus cancer. Maybe ethmoidal sinusitis.
Exactly. We have two cancer option, and I think it is not the age and it is not the complaint. So we exclude these answers. Nasal polyp is the same. It will not come with a headache or pressure between eyes. Okay. The other is maxillary sinusitis and ethmoidal sinusitis. Maxillary sinusitis will not reach the eye, and even the opening.
Fossa.
And the opening of the maxillary sinus, even it is just in the nodes, in the nasal cavity. But the only thing that between the eyes and make headache and make discharge is the ethmoidal sinus. So we between the ethmoidal sinusitis or ethmoidal sinus cancer, which will be enough. Child, it will be a ethmoidal sinusitis is the most common problem. Okay.
Okay.
Next question. Dr. Qada.
Okay. An 8-year-old boy presents with a lump in his neck. On examination, he is found to have a lump in the midline of the neck, immediately below the hyoid, which moves on tongue protrusion. What's the most likely diagnosis? Benign lymphadenopathy, malignant lymphadenopathy, thyroglossal cyst, branchial cyst, dermoid cyst. The mass is moving on tongue protrusion, so mostly in the midline, thyroglossal cyst.
Perfect. This is a child with a congenital thyroglossal cyst. So we just look when we're asking about the neck swellings, we have to look to very important 2 points in any lump in the neck. First point, you have to look to the age. Okay, it's very important, especially in thyroglossal cyst and branchial cyst. Thyroglossal cyst will be an early age, maybe branchial cyst will be in a later age, a little but still in young. Sorry?
Second decade for branchial cyst.
Exactly. So in the first decade, we have cyroglossal, second decade, we have the branchial cyst. And in the first 1 or 2 years, we have a swelling in the root of the neck, just behind the sternocleidomastoid. Anyone remember? And it's translucent.
Branchia will also not be in the midline.
Yes, Dr. Mumtaz. Cystic hygroma, perfect. Cystic hygroma, perfect, Dr. Mumtaz. As we said, okay, we have the sternocleidomastoid like this. This is the clavicle. Wait, this is not clavicle. Okay, this is the clavicle. So we have in the midline, young age, we have a cyroglossal cyst. In the anterior triangle here, we have the branchial cyst. Take care that it's in the submandibular region, and he tells you underneath the mandible, in the anterior triangle of the neck, you have the submandibular gland. Just below the sternocleidomastoid, here, you'll find the pharyngeal pouch. Sometimes he tell you just beneath the sternocleidomastoid. Just beneath, maybe sometimes just below. He need to tell you just below the sternocleidomastoid. In old age, mostly, in middle to old age, you have the pharyngeal pouch. Pharyngeal pouch. In young age, and it just here exactly, the angle of insertion of the lymphatic duct, because the lymphatic duct just, yes, you find here swelling, translucent in a child about 1 to 2 years of age. This is a cystic hygroma in the posterior triangle. So in the anterior triangle midline, in young age, you'll find the cyroglossal cyst just in the anterior triangle. In the second decade, you find branchial cyst just underneath the mandible. You'll find the submandibular gland in swelling, and it will be in the middle age or just maybe old age in cancer. In just below, just underneath the sternocleidomastoid, just below here exactly, you will have the pharyngeal pouch, and it will be in a middle age to old age, and it will give you a history of halitosis or bad breathing, bad smell breathing, and regurg of some food sometimes. This is a pharyngeal pouch, and in a child we discuss that in the pediatric surgery, in the posterior triangle, just in the lower half of the sternocleidomastoid, and it's translucent. It will give some like bluish discoloration sometimes if the child is white skinned. Exactly, you'll find like bluish swelling. This is a cystic hygroma. Okay, this most swellings that you'll have in the neck, plus the thyroid gland in the midline in young age. This is the thyroid gland and moves with deglutition. This is the thyroid gland, plus the thyroid gland, the most important for sure. Next question. Who? Dr. Sahab? Dr. Sahab? Are you ready? Okay, Dr. Mahbub, you can go. Dr. Mahkoub, you can unmute yourself and you can go.
Okay, so sorry, I was reading.
Okay.
18 years old boy present with pancreatitis. He has bilateral painful parotid enlargement. What is the most likely underlying cause? This is viral parotitis because of mumps,
Yes.
pancreatitis, and parotitis.
Yes. This is a child. Yes, you look to the age. So we say that bilateral may be sarcoidosis or Sjogren syndrome, but in a child with pancreatitis, or sorry, a very young age with pancreatitis, the most common here is viral parotitis, and sometimes it is associated with orchitis, encephalitis, or meningoencephalitis as well. So this is a viral, multisystemic viral infection because of mumps. Okay, next question. Dr. Ghada.
A 14-year-old boy presents with enlarged tonsils that meet in the midline. Oropharyngeal examination confirms the finding, and you also notice petechial hemorrhage affecting the oropharynx. On systemic examination, he's noted to have a splenomegaly. What's the most likely cause? Oral candidiasis, infection with Streptococcus pyogenes, infection with infection with Epstein-Barr virus, infection with the Staphylococcus aureus. It's Epstein-Barr virus. It's a glandular fever.
Okay, so this is a glandular fever or infectious mononucleosis associated with enlarged lymphatic tissue, mostly all over the body, including the tonsil, some pharyngitis, maybe neck lymph nodes, and splenomegaly. Okay.
Okay.
And by the way, one of the most important and very common question, and I did see many times in recalls about a young age child or young age at the same, maybe the second decade, and comes with spontaneous splenic rupture, and the child have no history of trauma, and also he have some lymph node swelling, or sometimes he didn't mention it. But what is the most common cause is infection with Epstein-Barr virus, EBV virus, one of the most common causes of spontaneous splenic rupture in young age. Clear?
Clear.
Okay. Next question. Dr. Fatima, you don't want to share, to participate with us? Okay, start again, Dr. Aruna.
Yes. A 70-year-old lady presents with a painless neck lump. There is a mass noted beneath the sternocleidomastoid muscle. There is a long history, and somewhat unkindly, her husband remarked on her rather noticeable halitosis. What is the most likely explanation? Branchial cyst, branchial fistula, pharyngeal pouch, thyroglossal cyst, dental caries. It is a pharyngeal pouch because of halitosis, noticeable halitosis, you can say.
Perfect. Perfect. That, as we said, it is an old age mass, not associated with any other symptoms like constitutional symptoms of cancer or swelling problem or voice problem, and associated with a halitosis, which has a bad odor of the mouth and breathing. So most common here is pharyngeal pouch. Okay, next. Okay, Dr. Sahar, you'll take your turn again, but after Dr. Ghada.
I just lost connection for now. I can see the screen.
Okay, so go for Dr. Sahar. You can go.
21
Dr.
years
Ghada, are you
old.
ready?
Just unstable. I have no
Okay,
connection
okay.
now. Okay.
No problem. Okay, Dr. Sahar, go.
21 years old man presented with unilateral facial nerve palsy after being hit on the head. On examination, he has right side facial nerve palsy and watery discharge from the nose. What does most likely causes? Polymorphic adenoma, cerebrovascular accident, occipital bone fracture, petrostemporal fracture, sarcoidosis. I
This is
think
trauma. Yeah.
trauma, petrostemporal fracture.
Petrous temporal fracture. Exactly. This is depends on the course of the facial. Where is the facial canal pass? In the petrous part of temporal bone. Okay. He
Yes.
just want to ask about anatomical question or anatomy question here, which is you have a facial nerve palsy. So which bone is fractured? Where is the facial canal pass? It's in the petrous part of temporal bone. Okay, so this is a fracture base exactly where in the petrous part of temporal bone. Next question.
A 4-year-old is brought to the general practitioner by her mother. She has been distressed with ear pain for the past 14 hours. She is constantly touching and pulling at her ear. While she is sat in the waiting room, her mother noticed a discharge of foul-smelling fluid from the ear, following which the pain resolved. What is most likely cause? Young age, ear discharge, and history of pain. This is acute otitis media.
Okay, exactly. This is a young or a child with a severe pain in the ear. And it's a very common question and a very common problem in childs. This is acute otitis media and very common to be perforated and discharging pus or clear fluid sometimes. Next question. Dr. Ghada.
Okay. A 40-year-old woman presents as an emergency with a painful mass underneath her right mandible. The mass has appeared over the previous week with a pain worsening as the lump has increased in size. On examination, there is a foresee a mass underneath her mandible. There is no associated lymphadenopathy. What's the most likely diagnosis? Submandibular gland cancer, submandibular gland calculus, carotid body tumor, papilloma of Wharton duct, or carotid body aneurysm. Painful mass and underneath the mandible, no lymphadenopathy, and she's young. Calculus, submandibular gland calculus.
Okay, so we just start with what is this mass most common. So this is the site of the submandibular gland. Okay.
Yes.
So the mass give positive pain, negative lymphadenopathy. Be clear. Be so simple. Be straightforward. This is a calculus. So if in your normal practice, it is not possible to have a cancer with pain, it's possible. Early cancer compressing a nerve like the lingular nerve, the hypoglossal nerve with some neuroma or invasion and have some pain and still don't have lymphadenopathy. So maybe the mass is cancer. In the practical life, maybe cancer. Why not? Maybe cancer and compressing some nerve and still there is no lymphatic spread. But here he wants to tell you, be simple. He tell you like babies in the primary school or students in the primary stages of school. Here is pain, positive and negative lymphadenopathy, so it is not cancer. Most commonly would be submandibular gland calculus. Maybe it is a 40-year-old woman. A cancer is common to happen, but he just wants you to be so simple and so superficial information. Positive vein, no lymphadenopathy, so it is not cancer. It is another problem like inflammation or calculus. Okay. Next question, Dr. Fatima, you want to ask?
Sure. A 46-year-old woman is
Okay.
referred to endocrine surgery for a possible thyroidectomy. She has attended neck swelling. Blood vessels are as follows: TSH less than 0.1, T4 188, HP 14.2, platelets 377, the PVC 6.4, ESR is 65. Technician thyroid scan showed decreased uptake locally. What is the most likely diagnosis? So,
What do you find from
it's
this investigation?
It's hypothyroidism plus ESR is high.
It's hypo
Hypo with a high ESR.
high
And so it's a
ESR.
subacute thyroiditis.
What's your answer?
Subacute thyroiditis because ESR is very high, 65.
Okay. Let's talk here. By the way, in actual exam and in all previous exams, you will have the normal range of any test together with the result of the test. Okay. He gives you the test and the normal value. So don't be confused or don't be scared or worried about this. He will give you the normal TSH and the level of TSH tested, because in many places all over the world we have different ranges of tests, and even you can find in the same country, from one hospital to another hospital or from one system to another system, we have different range or different values. So in the exam he will tell you. Here he wants to tell you that I have white blood cell count almost normal. Okay. ESR is a little or a bit higher, and T4 is high and TSH is low. So he wants you to tell you this is a subacute thyroiditis. So it's not acute bacterial thyroiditis. Is the white blood cell count is not so high, and it will be the TSH and T4 will be of normal value. But in subacute thyroiditis, what we said, I think decurvant thyroiditis, we have the T4 is high, TSH is low. Patient don't need surgery. Subacute thyroiditis is just with tender goiter, hyperthyroidism, and raised ESR. This is the comment about this question. Okay. The question in the exam will be more clear than this, by the way, and all recalls, all question about thyroid and hyper or hypothyroidism is much more clear than this. Okay. Next question, Dr. Aruna.
This 30-year-old lady is found to have a thyroglossal cyst that has been recently infected, and the patient requests treatment. What is the most appropriate course of action? Surgical treatment with resection of cyst, associated tract, central portion of the hyoid, and wedge of the tongue muscle behind the hyoid. Excision of the cyst alone with ligation of the tract. Laying open of the tract and excision of the cyst. Finalization of the cyst and marsupialization of the cyst. So the option may be the first one. Surgical treatment with resection of cyst, associated tract in central portion of the hyoid and wedge of the tongue muscle behind the hyoid.
Okay,
As the
what's the
cyst
name of
has been
this?
infected recently. Systrank operation.
Systrank operation, exactly. So here is the Systrank operation. We all know that seroglossal cyst, when infected, sometimes perforate or surgically drained by mistake as an anterior neck abscess. So it will be converted into a fistula. So whatever cyroglossal cyst or cyroglossal sinus or fistula, we do what's called Systrank operation, which is removal of the whole cyst and the tract and part of the hyoid and wedge of the tongue posteriorly. Okay, so this is a Systrank operation. Next question. Dr. Ghada.
Okay. 22 years old female attend clinic after noticing painless neck lump. On examination, she noted to have bilateral thyroid masses and multicentric masses near the base of the thyroid. Her corrected calcium is 2.1. What is the most likely diagnosis? This is medullary carcinoma with MEN 2A.
Medullary carcinoma with MEN
2A, yes.
So it is a young age female with painless neck lump, bilateral thyroid masses and multicentric. So it is a syndrome. It is not a solitary or what's called a sporadic lesion. So calcium is normal. So what is medullary carcinoma? It is the high normal of calcium, by the way. 2.2 is the high normal. So it is medullary carcinoma with associated. Okay, why it is not sporadic medullary carcinoma? Why it is not number A? Okay, just to differentiate.
Bilateral.
Okay, so in your exam, you will not face any sporadic medullary carcinoma, whatever. They like the other to talk about MEN syndrome in many questions, especially in medullary carcinoma. He won't tell you it is sometimes familial, bilateral and multicentric. And sporadic, it will be unilateral cyst or unilateral swelling and just solitary swelling, unilateral solitary swelling. So this is the sporadic type of medullary carcinoma. But in the familial or MEN 2 type, it will be bilateral and multicentric, and the patient will be a young female, mostly young female in second decade or maybe in the start of third decade, together with family history of MEN syndrome. Okay, this is the difference between the sporadic and the medullary type and the familial type. Next question. Dr. Fatima, if you want to, or Dr. Ghada. Dr. Ghada, then Dr. Fatima.
As a 45 years old man present with facial swelling. On examination, he has swelling that lies infralaterally to the nose. When the area is palpated, it feels like an underlying bone is cracking. What is the most likely diagnosis? maxillary sinus cancer, ameloblastoma, nasal polyps, maxillary sinusitis, and mucocele. So this is not mucocele, not sinusitis, not nasal polyp. So it's an ameloblastoma because the underlying bone is cracking.
Yes. So this is what we said, a sporadic question with no related other question, by the way. We have no other question related, just odontogenic epithelium from the dental. It is more an dental problem, by the way, or maxillofacial problem. One of the rarest question we see. It is ameloblastoma, tumor of odontogenic epithelium. Not confusing with any other scenarios, by the way. Next question, Dr. Ghada.
Okay. The same problem with my connection.
Okay, no problem.
Okay.
Okay, no problem. Okay, so Dr. Ghada Safa.
Okay, 42 years old singer is admitted for thyroidectomy. Post-operative, the patient develops stridor and has difficulty speaking. What the most underlying cause? Okay, he has a stridor. Okay, bilateral superior laryngeal nerve. No, unilateral recurrent laryngeal nerve. Unilateral superior laryngeal nerve injury. Bilateral recurrent laryngeal nerve injury, hypoglossal nerve. A stridor, so bilateral recurrent.
Exactly. As we said, bilateral partial will be aphonia, bilateral complete will be aphonia, bilateral partial will be stridor. Okay. Dr. Sahar. Okay.
Years-old woman present with diffuse swelling in the region of her right parotid together with facial pain. On examination, she has right side facial nerve palsy. What the most likely underlying cause? Polymorphic adenoma, adenotic cystic carcinoma, Wharton tumor, lymphoma, sarcoid. My answer, adenoid cystic carcinoma, because
Perfect.
facial nerve palsy.
Exactly. This is the most common malignant tumor with facial nerve palsy is adenoid cystic carcinoma, but it is not the most common malignant tumor of the parotid, but it's the most common with neuropathy or facial pain or facial palsy or epineural invasion. Okay, again, Dr. Aruna.
10-year bone wound presents with epistaxis. From which of the following regions is the bleeding most likely to originate? Posterior nasal space, alar ring, facial plexus, pebriform plate, none of the above. Kesselbach's plexus, because 10-year-old boy presents with epistaxis.
Kesselbach's plexus or Little's area. Okay. So here just want to clear one thing. Little's area. This is the nasal cavity, and this is the Little's area. Okay, on the nose. We have posterior superiorly. Wait. Posterior superiorly and anterior inferior. Anterior inferiorly is supplied mainly by sphenopalatine and the greater palatine arteries from the maxillary artery. So this is sphenopalatine, mainly sphenopalatine artery, and this is the most common artery bleeding, or greater palatine, whatever together, and both of them are from the maxillary artery. This is the anterior inferior part of the letless area. Okay, posterior superiorly, we have the ethmoidal arteries close to the ethmoidal air sinus up, and these are arteries from the ophthalmic artery. Okay, but the bleeding most commonly come from the anterior inferior part, from the sphenopalatine. So most common place coming from it is Kesselbach's or letless area. The most common artery is the sphenopalatine artery. Clear about letless area? Clear?
Yes.
Okay. Because sometimes he asks about the artery, sometimes ask about the area. Next question. Dr. Mahbub.
Okay, 56 years old man present with pale swelling in the upper part of the anterior triangle of his neck. On examination, a mass lesion involving a submandibular gland is identified. On CT scanning, this is shown to be a solid lesion. There is no regional lymphadenopathy. Two fine needle aspirate have failed to be diagnostic. Which of the following is most appropriate management option? Submandibular gland and two fine needle aspiration failed to diagnose. This is most probably submandibular tumor. So we will go to submandibular gland excision, total excision.
Yes, excisional biopsy.
Yes.
As I failed to know the diagnosis by the needle aspirate and the CT, so the CT gave me it as a solid lesion, and there is no regional lymphadenopathy, and the aspirate failed to give me any final or definite diagnosis. I can't go for neck dissection, because neck dissection you have to have a proof that you have a malignant tumor, unless you are doing frozen section intraoperative. Okay, and this is the most common, by the way. But as I can't, or I didn't till now reach a final diagnosis, so I have to do a submandibular gland excisional biopsy, and then if there is a problem or malignant, I go for the definite treatment of neck dissection. Okay?
Okay.
Don't be confused, as there is no proof it is a cancer. You can't go radical treatment for any tumor. It's medico-legally completely wrong. Even in breast, you can't do total mastectomy or radical mastectomy without having a proof in your hand that you have a cancer. Okay?
Okay.
Next question. Who's there? Dr. Ghada again, Dr. Ghada Safa, then Dr. Fatima.
36-year-old woman present with goiter is diagnosed with autoimmune thyroiditis. Which one of the following types of thyroid cancer she is predisposing to develop? Anaplastic, lymphoma, medullary, follicular, none of the above. She has autoimmune thyroiditis. If I choose, I will choose lymphoma, but I have no idea actually. Just
Exactly.
by luck.
No. Yes, this is exactly autoimmune thyroiditis or Hashimoto thyroiditis. Even in histopathology, you will find one of the most common feature is lymphocytic infiltration. So when it is converted to move to a cancer, it will move to a lymphoma. Okay.
Okay, thank you.
Okay, so Hashimoto will go for lymphoma. Next question, Dr. Fatima.
This old lady presents with symptoms of dry mouth that has been present for past few months. She also has a sensation of grittiness in her eyes. On examination, she has a diffuse swelling of her parotid glands. There is no evidence of facial palsy. What is the likely underlying diagnosis? Sarcoid, Sjogren's, adenoid cystic, tumorphic adenoma, and lymphoma. This is a Sjogren syndrome.
Exactly, either it's clear now, dry mouth xerostomia, and have some sensation of grittiness in her eyes. This is keratoconjunctivitis sicca. So this is diffuse swelling. So here he won't tell you no facial nerve palsy, so it isn't a cancer. So we go for Sjogren's syndrome. Next question. Dr. Ghada, if you're ready. Dr. Ghada Neg.
Okay. Yes. Okay. An elderly diabetic male presents with severe deep-seated ataxia and facial nerve palsy. He has completed a course of amoxicillin with no benefit. What's the most likely diagnosis? Malignant otitis externa, osteosclerosis, acoustic neuroma, Meniere's disease, and viral illness. A. Malignant otitis externa. He's diabetic, present with deep-seated ataxia and facial nerve palsy.
Exactly. This is a combined scenario for this a full picture of acute malignant otitis externa. Diabetic patient, mostly male, and deep-seated ataxia with facial palsy. So this is unfailed antibiotics. So this is malignant otitis externa.
Yes. And most common organism, I think, Pseudomonas.
Sorry. Yes.
Most common organism is
yes. Most common organism. So this is not. That's why it is not responding to amoxicillin. Exactly.
Okay. Thank you.
Okay. Next question. Welcome. Okay, Dr. Mahgoub. Or Dr. Aruna, sorry. Okay. Then Dr. Aruna. Dr. Mahgoub, then Dr. Aruna.
Okay, 25-year-old lady present with an swelling located at the anterior border of sternocleidomastoid muscle. The swelling is intermittent, and on examination, it is soft and fluctuant. What is the most likely diagnosis? This is brachial cyst. Adolescent, 25 years, and in the anterior border of sternocleidomastoid. So this is B, brachial cyst.
Soft and fluctuant is brachial cyst, exactly. Perfect. Next question, Dr. Aruna.
4-year-old child presents with a 4 to 5 day history of feeling generally unwell and also of having a sore throat. On examination, there is a marked cervical lymphadenopathy. The oropharynx is covered with a thick grey membrane, which bleeds following attempted removal. What is the most likely diagnosis? Acute streptococcal pharyngitis, infection with Epstein-Barr virus, diphtheria, Ludwig's angina, ingestion of caustic soda. So most likely to be a diphtheria because of the membrane and which bleeds following attempted
Grayish
removal.
membrane. This is diphtherial membrane in a young child, and this is a very common problem in young child. Okay, this is diphtheria. Thick grayish membrane is that bleeds on attempt removal, by the way. Some doctors try to remove this membrane, so the medication give more results because it is a toxic membrane and sometimes cause high fever and sometimes gastroenteritis. So sometimes some doctors try to remove it with hydrogen peroxide, by the way, but when you remove, it starts to bleed. So that's why this is the diphtheria is the most common cause. Okay, next question, Dr. Sahar. Dr. Sahar. It's not clear. It's not clear, Dr. Sahar.
Symptoms of chronic air discharge and right side.
You have a bad
43
connection,
years
Dr. Sahar.
old
Okay.
lady present.
Dr.
43 years
Sahar.
old
Okay, go.
lady present with the symptom of chronic air discharge and right facial nerve palsy. On examination, she has foul smelling fluid range from her right ear and complete right side facial nerve palsy. What the most likely cause? Adenoid cystic carcinoma, cholecystoma, acute otitis media, chronic sinusitis, cerebrovascular accident. I think cholecystoma. My answer, cholecystoma.
Okay, 40-year-old professional singer admitted to right thyroid lobotomy. Postoperatively, she is unable to sing high notes. Which of the following muscle is likely to demonstrate impaired function? This is superior laryngeal nerve, so this is cricothyroid.
Which of the following does not cause carotid enlargement? Liver cirrhosis, myxedema, amiodarone, tuberculosis, Sjogren syndrome. So it's amiodarone.
Which of the following time frames is secondary hemorrhage most likely to occur following tonsillectomy? Between 5 and 10 days after surgery, during first 6 hours after surgery, between 6 and 12 hours after surgery, upon resumption of normal feeding, between 2 and 3 days post-operatively. Secondary hemorrhage may be due to between 5 and 10 days after surgery.
Okay, 4 years old child is brought to the clinic by his father. They are concerned that because the child has been noted to have a small epithelium defect anterior to the left ear, and it has been noted to discharge full smelling material for past 2 days. What the most likely explanation? Otitis media, otitis externa, otitis media, preauricular sinus, cholesteatoma, long-standing pars flacidum perforation. Yeah, most likely preauricular sinus, by location, I mean.
"56-year-old man present with symptoms of nasal pain, insomnia, and rhinorrhea. He has been well until recently and has worked as a wood carver for many years. What is the most likely diagnosis? Ethmoid sinus cancer, ameloblastoma, maxillary sinus cancer, fibrous dysplasia, and hemiangioperocytoma. This is ethmoid sinus cancer because of long exposure to wood carver. The answer is A.
Sorry. Sorry, I mute myself by accident. And so, okay, it's clear now.
Yes.
Okay, so here, what we say about small sinus cancer? Yes, exactly. And I just asked what's the type of cancer you expect to be here?
Squamous.
Sorry?
Squamous.
Squamous cell carcinoma. By the way, in wood carvers or in carpenters, ethmoidal sinus cancer is very common. Sorry? And also squamous cell carcinoma and nasopharyngeal carcinoma are the most common cancer happen in these patients. Sometimes ask about nasopharyngeal carcinoma, sometimes ask about sigmoidal sinus cancer, or the type of cancer which is squamous cell carcinoma. Okay, next question.
82 years old lady is referred to the clinic with a recurrent infections and abscesses in the neck. On examination, she has a midline defect with an overlying scab which moves upward on tongue protrusion, which is the more likely diagnosis. Bronchial cyst, bronchial fistula, thyroglossal duct cyst, thyroglossal cyst, sebaceous cyst, dermoid cyst. It's thyroglossal cyst.
Exactly. I think it's a clear scenario. We said that recurrent infection or sinus or discharging sinus most commonly is in the midline, is a thyroglossal cyst. Whatever it is spontaneously ruptured or it is surgically mistaken and open and drained like an abscess.
His age is very old, 32.
Yes, it is missed by recurrent infection. By the way, it is because the abscess or the cyst may be small and forgotten and just not clear, and when it started to be infected and start to be discharging sinus, or the patient start to complete. Okay. Because from the scenario moves upward with tongue protrusion. It is not a branchial, it is not cyst or fistula, it is not sebaceous, it is not dermoid.
Yes.
So from scenario, it is a thyroglossal cyst.
I have a question.
Yes.
So why did you mention multiple abscesses in the neck and recurrent infections? Is it like going towards anything like tuberculosis, because it's not related with thyroglossal cyst? What I remember.
Again, if?
Like why they mentioned with the thyroglossal cyst, recurrent infections and abscesses in the neck. So is there any relation to that?
He tell recurrent abscesses. It is the same abscess. So, okay, so it is recurrent.
Okay, the same place, multiple time abscesses. Okay.
Okay, because any fistula in all the body, perianal fistula or any fistula, discharge, start to give medication, dry, close, and then start to collect again. When the collection be much more, start to overcome the obstruction or the closed epithelium, and then rupture again, and then abscess again, and so on. This is the history of recurrent infections and abscess in the neck. Okay?
Yeah, thank you.
Okay, let's pass this question now and go for this question. Okay, who's Dr. Aruna?
A 10-year-old child presents with enlarged tonsils that meet in the midline. Oropharyngeal examination confirms this finding, and you also notice petechial hemorrhages affecting the oropharynx. On systemic examination, he is noted to have a splenomegaly. What is the most likely cause? Lymphoma, acute Epstein-Barr virus infections, diphtheria, streptococcal throat infections, and quinsy. So maybe lymphomas or acute Epstein-Barr virus infection.
So, it's your final decision?
Maybe acute Epstein-Barr virus infection.
Exactly. They like it, by the way. Infectious mononucleosis or glandular fever. It will be presented by enlarged tonsils. Okay, meet in the midline means this is big enlargement, petechial hemorrhage and oropharynx, or sometimes he tell you pharyngitis, and splenomegaly, and this is a picture of Epstein-Barr virus infection or infectious mononucleosis or glandular fever. Okay, clear? This is multiple lymphatic system enlargement and inflammation or involvement. Tonsils, sometimes neck lymph nodes, sometimes splenomegaly, but he always combines the enlarged tonsils with the pharyngitis and gives you like petechial hemorrhage, especially if you give antibiotic like penicillin, will give the rash as well. Okay, next question.
Which of the following statement relating to branchial cyst is untrue? The greater auricular nerve may be divided during excision. Yes. They typically occur in young adult. Yes. They move upward on swallowing. This is wrong. That is thyroclastic cyst. They are rare over the age of 40. Yes. They are usually located in the anterior triangle of the neck. Yes. C. The
Okay,
answer
so
is C. Is untrue.
yes, it is not move upward with swallowing because it's a feature of
Thyroclastic cyst.
or thyroid.
Okay.
Okay.
Yes.
So let's come back to the question we passed. Okay. Who's there? Dr. Ghada.
8-year-old boy with recurrent attacks of otitis media is suspected of developing a glue ear. If his sound conduction is tested, which of the following is most consistent with a unilateral middle ear effusion? Negative Rene test on ipsilateral side, positive Rene test on the ipsilateral side, positive Weber's and Rene test on ipsilateral side, positive Rene test on the contralateral side, or negative Weber's test only on the contralateral side. Obviously, this patient has conductive hearing loss.
Hearing loss.
Yes, so we are dealing with Rene test. So Rene test to be positive, the air conduction must be more than bone conduction. When it is lost, it must be negative on the same side. So I think it's A, negative Rene test on ipsilateral side because of loss of air conduction.
Perfect, Dr. Ghada. Perfect, Dr. Ghada. I want just to end my discussion with this question. So anyone have a problem? Yes, perfect, perfect, excellent explanation. Yes, she's perfect.
Thank you.
Okay, anyone, not me, all the group is telling. Anyone wants to any clearance about Rene and Weber test, or it is not clear? Clear. All of you, it's clear. Negative and Rene test, no Rene and okay. If anyone wants me to clear it, just raise hand. Okay, Dr. Mahmoud, Dr. Shaima.
Just one question. In eMRCS, there was a table for both ipsilateral, contralateral, neurological loss and conductive loss. Can you just share it and explain it individually at the last of the lecture, please? Yes, this one.
This one?
Yes.
Okay, this one. Okay,
yes.
I just want first to just clear what's happening exactly and what we do in ENT examination. Okay. Because we have a long station even and 2 stations in part B about testing the testing the vestibulocochlear nerve and the hearing loss as well. Okay, and sometimes in posterior cranial nerve, posterior cranial fossa tumor. So what we do exactly, we have what's called Rene test. Okay, Rene test. Yes. We have a tuning fork. Okay.
Yeah.
We just it's about 512 decibel, I think, or something like that, or
Yeah,
it has, this is, yes, yes, hertz, exactly. We just make like turning this fork and just put this fork in the mastoid process where it's by its back. And then when the patient tell you, okay, I can't hear more, I can't hear more, this is, we put it in the bone. The bone means the sensorineural hearer. Okay, so if I have, this is the bone, and this is the bone, okay, like this. This is the bone. And from here is the air. Sorry. So from here is the air. The bone is conducted with the nerves. Okay.
Okay.
So this is the sensory nerve. So what I do exactly, I put the tuning fork in the bone, and when the patient stop hearing, I move it to put it in the air. And this is renetist. Normally, I have the air conduction is much more than the bone conduction. Okay, and this is positive renetist. If I have any block here, like blue ear, bony problem, or wax or something like this, okay, the bone will be more conductive than the air, and this will give us a negative renetist. Clear renetist?
Yes, very clear.
Please.
Yes.
Weber test. What we do in Weber test, we just put the tuning fork on the forehead, okay, and then it will go for bone on both sides. We'll go for bone here, and we'll go for bone here. Normally, in Weber test, okay, the patient will hear the voice in both sides the same, okay?
Okay.
But if I have an conductive hearing loss, if I have a conductive hearing loss here, the ear is blocked. This ear will hear the voice more clear because we abolish the noise of air, which decrease the hearing of the ear. Is clear, or I make it again? Okay. The air decrease the hearing of any voice. So if you just hear 8 decibel, if I abolish the air, you will hear 10 decibel, because normally the air decrease the hearing and the sounds in the ear. I feel you confused. Again, in Weber test, normally I hear in both sides. Again, normally I hear in both. It's clear. Okay. Normally I hear in both sides is normal. I hear in both sides the same. But if I have an air problem in one side, I'll hear the voice or the sound. It will be more clear in this side because I abolished the air of the air conduction. It's simple, like I'm at home or I'm at my office and I just opening the window and I have much air, and I'm speaking with some of my friends, and then I just found that he can't hear me good. When I just close the window, we can hear each other more clear because I abolished the disruption or the distraction with the air.
Okay, what about the lateralization to the left and to the right involving the Weber test?
Sorry, again.
What about the lateralization for Weber test, to which because to the opposite side or contralateral side, when it's positive in one side in the left, so there is loss on the right, and vice versa?
Okay, I just want to clear. Weber test, you do it after Rene test. Okay,
Yeah.
just to confirm, you have an air conduction problem in one side, because if you have a bone conduction here, maybe
yes,
the voice will be more here. If you have a sensory neural problem here, or the nerve, it will be on the other side more clear.
more clear, yes.
But if you have an air problem here, sorry, if you have an air problem here, the voice will be more clear on the air problem. Should be combined with Rene test.
Yes.
Okay.
Okay, thank you.
Let's go for the table.
Yes. Okay.
Okay. Weber without lateralization, but I just want you to lateralization will just confuse you more. Okay. Forget about what's lateralization. Just go. Sorry. It's confusing a little bit, but just go. Here is Rene test.
All about the lateralization. Yes.
Okay. Here is the table. Both ears, air. Both ears, air more than bone. So this is normal, yeah?
This is the normal.
Go
yes.
for. Okay. Weber went to the left side. Weber went to the left side. Here tell you air, Rene test is positive, air more than bone. So here the air is good, so the conduction is good. Okay?
Yes.
Here is Rene test. This is right. So here is conduction is good. So I just want to know where is the problem. The problem will be most commonly in the bone or in the sensory neural.
Yes.
Weber went to the left. So I have a problem in the right. Weber went to the left here. So here is a problem with the bone or the sensory neural. Because air, I excluded air is good. Air on both sides is good, but with bone, it went to the left, so the right have a problem.
Yes,
next
right.
example. Here,
Clear.
left bone more than air. When I found that on the left side, the bone is more, so I have a conductive hearing loss on the left side.
Left side, yes.
Okay, I have a conductive hearing loss on the left side. I make Weber, and Weber went to the left. Okay, so this is still conductive hearing loss on the left. Okay, because it abolishes the air, and the left will be more clear because I close the window. So still I have a conductive hearing loss. But if I found the Weber went to the right, I have both sides, bone and air conduction lost. So I make Weber here, so it went to the right and left to the, and the left no. So I have from Rene, I have conductive hearing loss, and from Weber, I have bone hearing loss, so I have combined hearing loss. Anyone confused, raise hand. I know it's confusing. Okay.
No,
take another example.
Much better, thank you.
Okay. I have in the right bone more than air. So I have a conductive. Now I have a conductive hearing loss on the right side. Let's go for Weber. If Weber went to the left, okay, so on the right side, I have conductive hearing loss, and on the right side, I have sensory unit hearing loss, so it is combined. It's not transmitting air or not transmitting both. But if it went to the right, so I just have a conductive hearing loss on the right, because this is normal. When I have conductive hearing loss on the right, the Weber gives me more hearing clear on the right side where the windows are closed. Okay. And so on. Just need to concentrate to know it. Okay. Read it and draw it, and you will understand it. Clear?
Yes.
Clear.
Okay. So by this question, we end our discussion. Wish I could help you. We'll send you the record as it's soon processed. I'll close the record now, and if there is any question, we can complete. Thank you for all, and wish you good health and safety and good study as well. Thank you.
Thank you. Thank you very much.